When I talk about morphology, that's actually the shape. As mentioned earlier before, force causes fluids to move, while gravity is a force, and it comes into play with poor standing and sitting postures. One obvious example is the forward head carriage. If you think about it for a minute, it becomes quite clear. The force of gravity acting on the forward head causes fluid to move in the upper thoracic and lower cervical spines. The pressure is now greater in the anterior aspects of these structures, and fluid therefore moves to the posterior. This movement causes sagittal wedging, changes the shape in the discs and the vertebral bodies. The head now stays forward, and the scenario quite often worsens over time. Muscles adapt to this, and an upper cross syndrome develops, as well as an associated cranial nerve involvement. This is really big. Only by reversing the fluid shift within these parts of the spine will the condition be corrected. The therapeutic direction of force has to be opposite that of gravity. Just because a patient looks as though they have a forward head carriage, that doesn't mean theirs is symptomatic. That's why we test for it. Likewise, a patient presenting with a seemingly good posture doesn't mean they don't have a forward head posture for their particular case. That's why we test for it. Several techniques can be used to test and treat this condition. And particularly with this, so you got to look for red flags. Anytime we extend the neck, we got to look for red flags. A second example is the misshaped lumbar vertebral discs, bodies and discs, due to sitting slouched or standing stooped for long periods, which we do in our society now. Again, the testing would involve introducing the force into the lumbar spine opposite of that of gravity. General considerations: without reshifting the fluid in these areas of the spine, any treatment would only be limited or have short-lived results. The patient should be educated to what has happened and given a few simple home exercises in order to self-correct. Best practices states that patients should become independent of care as soon as possible. Now that the head is back, it's time for muscle lengthening procedures to be applied to the hypertonic groups, followed by strengthening exercises for the inhibitor groups. The same applies for the lumbar spine. Okay, so we can observe with the forward head posture, quite often the whole of the ear is quite a bit ahead of the AC joint. Every degree the external auditory meatus is ahead of that AC joint. There's increased pressure on the discs and degeneration. Along with this, you get the upper cross syndrome. Some groups of muscles are too tight, some groups are inhibited. But it's actually the shape of these vertebrae, the lower cervical and the upper thoracic, it's the shape of these vertebrae that's holding this position. So if we can change the shape, if we can shift the fluid in these vertebrae so everything comes back, that's what we're looking for. So we're going to try this. I'm going to show you this procedures to test and treat this in the seated position, in the prone position, and in the supine position. Would you like to sit down? So in order for me to move that fluid in those vertebrae, I actually have to increase pressure in the vertebra, just as gravity increased the pressure in the vertebra. But this is going to be in the opposite direction of gravity. My knee's the fulcrum now. You would put your arms up, please. Just like this. Everything all right? Now, as I pull her back, the pressure of her thoracic spine on my knee increases, and that's moving the fluid. You all right? Then I relax. I wait for a physiological response, particularly if anything's going the wrong way. Everything okay? Yeah. Can I do it again? Yeah. I got to hold it long enough to give that fluid a chance to move. Change my position. Maybe I'll go up a little higher now. All right? And relax. Now, I don't get the upper part of the thoracic spine or the lower part of the neck. We can do this in the chair with the back. Come and sit down in the chair. The fulcrum now is going to be the top of the chair. We don't use your shoulders. Just let your head come back. And you can see the fulcrum here. It's a little bit higher. And as I increase the pressure in the posterior aspect of these vertebrae, the fluid moves forward. Can I do that again? Yeah. Quite often there's a dramatic effect immediately after. Okay. Now it's important with this, I keep the eyes open, because as I put her head back, I got to make sure there's no nystagmus or any vascular kind of compromise. Okay. And you notice as I go back, her neck is in the neutral position, just as in the seated position. I don't extend the top part of the neck at all. It's just the lower part of the neck and the upper thoracic against the fulcrum. You all right? Yep. Can I do that again? Look into your eyes, always get a response. I look in the eyes for nystagmus, and plus I look in the eyes because I can see an emotional change before anything comes out of the mouth. Can I do that again now?
Yeah.
I can add some traction. Okay. If going backwards increases the pain in the arm, obviously we're going to stop that. Quite often when we go, this is very effective, but quite often when we go backwards like this, what happens is the semicircular canals are in a funny position, so they might get some vertigo sensation. So we can adapt the procedure. We can adapt the procedure so they don't have that. Okay, up again now. So we can do it in the prone position. We're going to do this a little bit differently. Let's have you lying down on your tummy. I want your face here though, and your feet way off the edge, way down the edge. Come back some more. Okay. And you just let yourself go down flat. Just turn your head to the side. Slide down a bit more. You all right there? And just let yourself down flat. And this way. Let's put this belt on here a little better. And now we're extending that area of the spine, and the semicircular canals are in their neutral position. Once you have your goal of targeting the area to decrease the pressure to allow the blood flow, that's like a compass or like a North Star for you. So if a certain technique, a certain method of doing it doesn't work for that individual, you can change the procedure up such that it does work and you still achieve the goal that you want. When we talk about the lumbar spine, let's have you slide up forward for me. Right about there. Come back a little bit. We want to extend the lower lumbars, extend them because when we sit flex, you stand stooped. We get wedging in that area as well, and if we want to drive the fluid in the opposite direction, instead of from the posterior to the back, we want to drive it from the front back to the post the other way. Now I'm driving the fluid in the opposite direction of when you're sitting flexed. Can I go a little higher?
Yeah.
And you might want to do a little bias. You might want to come over one way or the other. You all right? You got to hold it long enough so that fluid shifts. This is going to change the lumbar curve, just as it's going to change the lordosis, just as it's going to change the kyphosis in the upper thoracic and lower cervical curves. And as mentioned before, it's very important to educate the patient as to what's going on so they understand and they can self-treat.